Welcome to the National Press Club in Washington, D.C. and to the Miller Center National Debates. Tonight we focus on the question of whether the United States should ration costly end-of-life care. Arguing that the United States should ration end-of-life care is Ira Byock, a doctor, a professor at Dartmouth Medical School, and a director of palliative medicine at Dartmouth-Hitchcock Medical Center in Lebanon, New Hampshire. His teammate is Arthur Caplan, director of the Center for Bioethics and a professor at the University of Pennsylvania. Arguing that rationing is a bad idea is Ken Connor, chair of the Center for a Just Society and a lawyer in private practice. He represented former Governor Jeb Bush in defense of Terry's Law, the legislation named for Terry Schiavo. He's a former president of the Family Research Council. And his teammate is Marie Hilliard, Director of Bioethics and Public Policy at the National Catholic Bioethics Center. She's also a registered nurse.
Every day, families face wrenching decisions about end-of-life care for elderly grandparents, premature infants, family members with terminal cancer, or victims of extreme trauma. And sometimes individuals face those decisions about their own care. Some say because the U.S. has the best medicine in the world, Americans are entitled to take advantage of all of it. But often, families bankrupt themselves in their struggle to keep loved ones alive a week or month longer. Religious and spiritual beliefs also play a role in their decisions. Many believe that if they have health insurance, they can spend at will, even if it means higher premiums are passed on to their fellow workers. A recent Gallup poll noted that 93% of Americans say it is either extremely or very important for their health care plan to cover any medical test or treatment they and their doctor think is necessary. Medical costs at the end of life are especially high, with more than one-fourth of Medicare expenses in 2009, about $143 billion, going to treatment in the last year of life. And without changes, the current Medicare program will be insolvent in 7 years. The enormous costs have led some to ask if health care should be rationed at the end of life. And who should make such decisions? Insurance companies, the medical community, the government, or a panel made up of representatives from each of these groups? Many argue that rationing already takes place. Insurance companies limit the number of paid hospital days. Emergency rooms triage patients. And the recent H1N1 swine flu vaccinations, available in limited amounts at first, were prioritized for healthcare workers and those at most risk. Others argue that rationing is a slippery slope, and that healthcare decisions should be made by patients, their doctors, their families, and perhaps a religious or spiritual advisor. They believe that rationing care is unethical, that it could unfairly impact the poor, can be arbitrary, and would only result in small cost savings. Others argue for what they see as a more rational approach to end-of-life care, with greater use of advanced directives and hospice care, and better information about treatment options and their success rates. While cases such as Karen Ann Quinlan and Terry Schiavo make headlines, most people don't have to deal with such extreme situations. But end-of-life care is an issue everyone will have to face.
Again, our debate resolution is the U.S. must ration costly end-of-life care. Up first, arguing in favor of the resolution, is Art Caplan.
You know, it's difficult to go to the doctor. We get news we don't like. Sometimes we get told to do things we don't want to do. Lose weight, wear a helmet when you ride your motorcycle. I'm here to tell you some news that's difficult. We are in a situation where we are going to have to ration health care. It's not news we like to hear, and when I say rationing, I mean pretty simply that we can't get everything we want when we're dying. I think we have had in this society, until very recently, a technological blitzkrieg for the dying. Almost anything and everything that we can imagine is applied to those who are in the final days of dying. It becomes difficult to move them away from that technological assault. It's hugely expensive. Until very recently, we paid for it by a heinous form, morally, of rationing, and that was to exclude 40 million of our citizens. We help pay for the dying and what we do by leaving many people uninsured. Well, we've made some progress and started to repair that. But the question now is, how are we going to afford to continue doing what we do at end of life? The situation is going to get worse. We have a situation where the population is aging. People over 65 consume 3 to 5 times as much medical resources as those under. We all know what the statistics look like in that Medicare program, where huge sums of money are being spent on the final days. And there is more technology coming in the pipeline, more things to spend on, more things that people want. So I contend, and our team contends, that rationing is something we do. We can't give everything to everyone even now. We only did it in the past by excluding people. Every nation on earth has to ration. They all do. We will too. We're going to have to make some hard choices at the end of life, and the demand curves indicate that that's just a necessity. The issue isn't whether we're going to ration. The issue is how. How will we be fair? How will we be just? How will we not pick on particular groups and discriminate against them? And can we allow people to have the kind of dying that they want? I don't believe they want that technological blitzkrieg in their final days. Many do not, and one form of rationing is to ask people to forego. But we can't continue the way we are. We rob our young to treat our dying. We don't educate. We don't do the infrastructure. We don't do the community justice by pouring resources into the final days of life when there are more possibilities open to us for the young, for the next generation, for those to come. So I think the issue is not, should we ration? It's how will we ration?
Thank you, Art. Now arguing against the resolution, Ken Connor.
Art, the very last thing the American people want is to have a bunch of bureaucratic bean counters in Washington, D.C. dictating to them how medical decisions are going to be made at the end of life. Medical decisions are best made by people who are at the bedside, families, physicians, the patients themselves. They should be made by the people who have their feet on the ground and who are in touch with the real-world conditions and whose primary motives are not to save money. Americans don't want cookbook medicine. They don't want one-size-fits-all solutions that don't take into account their particular situations. They want their doctors to be able to make judgments about things that are in the best interest of their patients, and they don't want their doctors straitjacketed in a bureaucratic straitjacket. Now, let's not kid ourselves, folks, about what rationing at the end of life means from a government standpoint. It's an embrace of a philosophy that was advocated by Governor Richard Lamb, who said that the elderly have a duty to die and get out of the way. Rationing at the end of life will inevitably wind up leading to a devaluation of human life. It's a euphemism for your useful life is over and the cost-benefit ratio is now skewed against society. That mindset, I would submit, endangers not only the elderly, but also the infirm and handicapped of any age, indeed anyone who costs more to maintain than they produced. Government simply can't be trusted to make life and death decisions for the infirm. It's already shown itself to embrace a utilitarian, disposable man ethic. The folks who brought us the disposable man mentality of Roe versus Wade and the Tuskegee experiments won't hesitate to apply the yardstick of inconvenience to those whose quality of life is diminished or who cost more to maintain than they produced. There are better ways to balance our budget than on the backs of the sick and the dying. Estimates are that the Medicare and the Medicaid programs are being defrauded of over $60 billion a year. Why not turn the screws on the perpetrators of the fraud rather than on the patients who are supposed to be the beneficiaries of such programs? Something is profoundly wrong in America, I would submit, when we can spend trillions of dollars bailing out banks and brokerage houses and the big dogs on Wall Street who are the victims of their own greed and selfishness, but we're going to deny medical care to those who are sick and dying. and so to the proposition that government bureaucrats should have veto power over the reasoned decisions of physicians and patients and their families as to what treatment is necessary at the end of life. I maintain that we should just say no.
Thank you, Ken. And now we'll hear from Ira Byock.
Rationing is such an emotionally charged word, which may well serve for an exciting debate tonight, but I think there's actually a more exciting opportunity available to us. It's to transcend the divisive terminology of rationing and reframe and refocus on the core challenges we all face and the goals we share. At the most basic level, we human beings live on the Earth. Less than 25,000 miles at its widest circumference, less than many of us drive every year, hurtling through deep space, protected from the frigid galactic void by the thinnest layer of air. The fundamental question that confronts us all is, how then shall we live? Within this encompassing question, the focus of tonight's discussion is, how shall we care for one another through the end of life? On this small green planet, we have finite resources, and our challenge is to allocate them fairly, justly, wisely, and humanely. As has been pointed out, we already ration, we just don't do so very well. Some rationing, of course, is embedded within the morals of our culture. When a ship is sinking, the call goes out for women and children first, and few of us would call that immoral. Both as a father and as a citizen, I would readily accept some rational limits on treatment for my own far advanced condition, heart disease, lung cancer, liver disease, in order for my daughters and their children to have access to health care that they need. One would think that mortality would be the ultimate unifying force that brings all people together. Instead, ironically, mortality has recently become a polarizing political topic. A cultural chasm of distrust threatens to divide Americans. Some allege that in allowing people who are approaching the end of life to die gently, without subjecting them to CPR and breathing machines and dialysis and feeding tubes, doctors and nurses are guilty of promoting a culture of death. In truth, the professionals who work in America's ICUs, cancer centers, hospice and palliative care programs are the most pro-life segment of American society. A reverence for life permeates the work that we do. But to truly affirm life, one needs to affirm all of life. And that includes the part we term dying. In upholding the inherent value of human life, we cannot act as if dying is optional. Both as individuals and collectively as a society, we must understand that some treatments are, when they're intended to save or prolong life, make no sense at some point. We need to decide when they do and when they don't. Since we are mortal, more treatment is not always better. Sometimes it makes things worse. Sometimes it actually hastens death. In asking how shall we care well for one another, it is also proper to ask how can we help people to die well. Although debates depend on heated differences of opinion, my hope is that we can transcend hyperbole and come together to recognize common challenges and as influential voices in our national community help lead constructive dialogue.
And now we will have an opening statement.